Hi guys. So we are getting into the critical alterations. Okay, I've covered all of just the alterations in gas exchange. Now we're getting into the critical alterations in gas exchange. Okay, the first one that we're going to touch on is pleural effusion. Okay, pleural effusion. So your pleura, okay, your pleura is that lining of tissue that covers the inside of your chest wall and the lining of your lungs. It's just a little skinny space, okay? That's your pleural space or your pleura, all right? And in that space, you usually have about 10 to 20 cc's of fluid, okay? The reason you have that fluid is so when the lungs expand and relax, okay, inspiration, expiration, when that happens, it's not rubbing like this. If that fluid wasn't in there, it would be rubbing like this. But because the fluid is in there, it makes it easily movable, okay? It decreases that friction. So when we have pleural effusion, it's a buildup of fluid in that space, okay? A buildup of fluid in that space that exceeds that 20 cc's, all right? And it could be many different types of fluid. All right, many different types of fluid, and sometimes even air, okay? But the fluid could either be clear, purulent, bloody, okay? But that buildup of fluid in that pleural space, it stems from either infection, inflammation, injury, okay? And it's categorized in two different categories, transudative and exudative. Okay, you have a transudative effusion that comes from an imbalance in pressure in your capillaries of the lungs, okay, usually stemming from heart failure, congestive heart failure, cirrhosis with ascites, okay. And then your exudative effusion, this occurs from an increase of capillary permeability, creating a protein link and a buildup of fluid in that space from inflammation. So transudative, okay, imbalance in pressure coming from heart failure, cirrhosis with ascites, okay, actual disorders. And then you have exudative that stems from your inflammatory response or inflammation from bacteria like pneumonia, tuberculosis, and things like that, okay? So pleural effusion, again, abnormal fluid buildup, okay? Too much fluid is in that pleural space. Okay, we already have 10 to 20 cc's. That's normal. We're supposed to have that. And it should be straw colored, okay, translucent. And it should just be chilling in there to help so it won't friction, okay, when we breathe in and out. But when we have too much, then it becomes a problem, okay? Then it becomes an issue. And some risk factors for this is peritoneal dialysis. Okay, and some medications can also cause this as well. Peritoneal dialysis, it's a form of dialysis that they insert hypertonic solution into the peritoneal cavity in the abdominal region. So just like we have our pleura, okay, that lines our lungs and in between our chest wall, we have our peritoneal cavity that kind of protects, it acts like a protective covering, kind of similar to our pleura, okay? And with peritoneal dialysis, there's a tube put into that peritoneal area, and they'll input hypertonic solution into that area, okay, to help draw out the fluids, the excess fluid from the body, okay? And it'll drain out of that tube into a bag, all right? That's a different form of dialysis. You guys will learn that in term 3. It's a different form of dialysis that they do to try to get the fluid out of the body. Okay, so that is a risk factor. Peritoneal dialysis is a risk factor for pleural effusion. Okay, granted, it's because the fluid is trying to get out. Okay, it has no business building up into one area. The fluid should be, circulated through the body and even across the board. But once we have fluid trying to pool in one area, it's going to try to get out and go everywhere where it has no business going. Okay, so decreasing the risk, there's other risk factors associated with comorbidities, and I mentioned the cirrhosis of the liver, left-sided heart failure, congested heart failure, nephrotic syndrome, cancer, inflammatory disorders, etc., etc. Okay, decreasing the risk of this pleural effusion is dependent on the underlying cause. The risk factor. Reducing that will reduce the risk of developing pleural effusion. Okay. You pretty much have to get rid of whatever the cause is. Okay, you get rid of the cause, then you reduce the risk of developing it. So what does it look like? What are our patients going to present with? Their manifestations? Dyspnea, as they all, will have dyspnea, that difficulty breathing. Pleuritic chest pain, particularly on inspiration. Why? Because the lungs are trying to expand and they're hitting that pressure, the pressure, the buildup of fluid in that pleura. All right, so inspiration is going to hurt. All right, it's going to either be mild or severe. They will complain of sharp stabbing pain. And the pain can also radiate to the shoulder or the abdomen. They may have a mild cough, but it will not be productive. The fluid is in the pleural cavity, not the alveoli. So there will not be any productive cough. But they can have some cough. All right, cough, just not productive. They will complete an X-ray. The X-ray will show a bilateral pleural effusions. All right, it'll have cloudy areas at the base of both lungs. Where the fluid is building up. They will do a thoracentesis. To remove the excess pleural fluid from the lung, and they will use an ultrasound to kind of guide the needle placement. All right, so they're not just sticking them and going in blind. But your thoracentesis, they take a very long needle. They use an ultrasound to guide the needle into the thoracic cavity, into the pleura, and then aspirate the fluid out. That is a thoracentesis. That is very, very helpful for determining, what is the cause? What is the cause of this fluid buildup? Because once we aspirate the fluid, now we can get good characteristics. What does the fluid look like, right? If it's bloody, bloody fluid, that indicates trauma, hematoma. So it's blood in there, If it's a milky color, that means that fluid has been present for a long time. If it's purulent, then it's stemming from some type of infection. If it's viscous, very thick honey consistency, then that could mean that there's some mesothelioma present. And if it's clear straw color, that's normal. That's what we want to see. But if it exceeds that 20 cc's, we want to know, what's going on? Why is there too much fluid in here? All right. But further labs will need to be done, especially on that fluid, to gather more information. And get down to the bottom of why. Why is this occurring? Is it an infection? Is it heart failure? Is it cancer? Whatever, There will be some lab tests of total protein, LDH, WBCs, RBCs, bacterial cultures, especially if it was a purulent fluid coming out of there. So your role as the nurse is to monitor the vital signs, monitor the respiratory status. All right, if they have a chest tube, you want to monitor the connection and the drainage. Make sure there's no bubbling in that chamber. Drainage, what's coming out? What is coming out? What is the consistency of it? All right, you will assist with the thoracentesis if it's done at the bedside. And you maintain oxygen delivery. Monitor for dehydration. This is a big one. This is big. Oxygen therapy will also dry out the mucous membranes. It does that. It dries out your mucous membranes. But you also want to monitor for dehydration anytime there is any alterations in fluid levels, whether it's too much, too little. You need to be aware of dehydration. You need to be aware of electrolyte imbalances. Anytime you're dealing with fluid. All right, but monitor for dehydration. I can't stress that enough. With your pleural effusion. Your client education. Recognize the manifestations. Look for their signs and symptoms. Know when to notify the provider. Don't just be calling them, bugging them. They're gonna call. Say you told them something that you just called them about 5 minutes ago. They're gonna be like, why are you calling me? Medications, treatments, and have them maintain a healthy lifestyle. You also want to perform a frequent focused respiratory assessment. All right, look at their thorax, their neck, okay, their oral cavity, their mucous membranes in the mouth. Make sure it's not blue in there. All right, you need to do focused assessment. All right, inspect for signs of respiratory distress. All right, increased respiratory rates, decreased O2 sats. Client positioning is big. Sit them up, high Fowlers. All right, changes in cognition level. All right, if not enough oxygen is getting to the brain, their cognition is gonna be a little weary. All right, they're not gonna be all there. They're gonna be confused, delirious a little bit. Okay, again, I mentioned the cyanosis, but don't just look in the mouth, look in the conjunctiva. Okay, nasal flaring. If they're struggling to breathe, their nostrils are going to flare outward. Intercostal retractions. This is where they're trying to breathe and their diaphragm is overcompensating. So when they try to breathe, their rib cage is going to be more prominent and protruding outward, and their abdomen is going to be retracted inward. Okay, increased work of breathing. They're trying too hard to breathe effectively or efficiently. All right. Respiratory associated pain. I told you guys on that inspiration, when those lungs try to expand, it's going to hurt really, really bad. Okay. Auscultation is used as well to identify any decreased or absent or adventitious, there's that word again, lung sounds. Okay. With pleural effusion, lung sounds may be dissimilar from side to side. Okay. They're not going to sound the same. Any one side could be muffled or diminished, and that should be noted. Something should be done about that as well. Okay. So, analyze your cues. Diminished and muffled breath sounds, pleural rub on affected side, sharp pain, all right, dyspnea, elevated vital signs, pain, especially pain with positioning and with breathing. Prioritize your ABCs, then your pain management, vital signs, respiratory assessment, and reassess and reassess and reassess. Chest tube management as well. Make sure you're looking at that drainage system, making sure that water-sealed chamber, there's no bubbles, no leaking going on. Okay? Generate solutions for your patient. Respiratory assessment again, vital signs. Okay? Pain assessment, oxygen requirements. Okay? Don't over-oxygenate either. Say they needed immediate oxygen. Okay? They were sitting at 80, 85. Okay? So you did high flow oxygen, but wean them off. Okay? Wean them off. We don't want to over-oxygenate them either. Okay? Medication administration, educate them on what's going on. You want to provide any assistance that you can with any of the procedures or diagnostic testings. Okay? Be of help. All right? Improvement of oxygenation greater than 95% is the goal. Okay? You want the dyspnea gone. Okay, that struggling to breathe, okay, that extra work that is taking them to breathe, you want that gone. You want that improved on, okay? So that's what you're going to evaluate. You want them to no longer be cyanotic, okay? Their mucous membranes and all that should not be blue. You want them pink, all right? Pink and moist. Lung sounds should also be clear. Vital signs normal, all right? Pain has been alleviated or reduced, okay? Lab results should show a reduction of white blood cell count, especially if that fluid that was taken out of or aspirated out of that pleural cavity was purulent. Okay, and now they've been giving antibiotic therapy. Okay, if it was a form of bacteria that was causing it, we want to see that WBC, that white blood cell count, start to trend down. Okay, in absence of drainage from the chest tube. Okay, if there's no more drainage coming out, the chest tube can be removed. Okay, so those are things that we want to see with the pleural effusion. Okay, after you do your evaluation, improvement. All right, if it's deteriorating or if it's staying the same, we're gonna have to run it back. Okay, happy studying.